what I found out that what efforts we making, there are small gaps, and they're just small gaps. We are not doing anything great. We're not doing anything great. Everything simple. In fact, my skills are much lower than what people have. I don't put IUJV line. PIC line I put once in a month or once in 2 months. In fact, art of intubation is going away. What I've found out, put the small gaps in place and babies will survive, most of them. With that, I'll say what's the gynecologist, what's the role of gynecologist, and start really the gynecology role start, and it ends there only. If the baby makes it to 7-10 days, they will survive, all of them. So first of all, there should be an ideal delivery time. What we do is we get scared sometime, and we don't explain the parent, and we are scared that the baby dies in utero. What happens? I think we have to sit together, talk to them, tell them that there is a risk of death in utero and outside also. Believe me, the risk of death outside is much more than in utero, and they'll end up losing more money and not having a baby. In India, whatever evidence we have, that is from West. In India, the death of newborn is much more because of infection. At least inside, the infection risk is lesser. Even in PPROM, if you give antibiotic to the mother, at least circulation is taken care of by the placenta, and the antibiotic reach the baby as much as it gets ex utero. So PPROM is never an indication for a very early delivery. Then is the preparation, how the gynecology prepare the baby. Steroid usually decrease the death by at least 50%. So dexamethasone in India, no betamethasone. If you give betamethasone, the frequency is as much as dexamethasone, and it's a little costly, not that much, but the frequency has to be as much as dexamethasone. Even a single dose of dexamethasone improves outcome. Some high risk that we have to let the pediatrician know that have you checked for it. We have to question the pediatrician. Have you checked for it? A baby who's been IUGR, you have to ask them, you have to call them, what are the sugars? Is the baby very polycythemic? If they're absent and diastolic flow, when you will start the feed, are you very aggressive with the feeding? Because it increases NEC. If there are PPROM, you ask the resident, have you taken a high vaginal swab? What were the results? And have the pediatrician started a sensitive antibiotics? Not a very high grade antibiotic. No, antibiotic kill more baby than save them. Antibiotic is associated with late onset sepsis, more NECs. So antibiotics are not the saver, but yes, they are the rescuer sometimes, not always. Maternal drugs, some maternal drugs are associated with fetal outcome, like nitrates we give for BP, they are associated with fetal methemoglobinemia, and sometimes baby desaturate, and we just keep on increasing the pressures. At least ask your pediatrician, have you checked the methemoglobin level in your gas? That will go a long, at least we have found 5 high methemoglobinemia in babies, just those mothers who were preeclamptic. Because we seen it before, but most of my resident don't know. Sometimes no, sir बच्चा तो ठीक है, बहुत डिसाइड कर रहा है. मैंने यार मेथाग्लोबिन देख ले, हमेशा नहीं आता, but 1 in 10 तो आ ही जाता है, स्पेशली जो प्रीक्लिम्टिक मदर होती हैं. This is ACOG का एक पेपर था. Last was in 2025 updates, and I'm not going to go about them. It is all available with you. It's freely available. Find it on the net and see where we when to deliver. Hardly there is a indicated delivery less than 28 weeks. Hardly. Only if the Doppler changes are so bad that rectus venous flow is reversed, then only we need to deliver it early. Otherwise, hardly we have to deliver less than 34 weeks. So that we can go. I'll not go deep into that, but yes, they have given, and we can find out. And one thing is sometimes late preterm birth. So really we want that late preterm birth. Late preterm birth, like I've seen, at least 1 out of 5 late preterm birth end up in NICU, either because of hypoglycemia or because of respiratory distress, and NICUs are the most unsafe places. I believe it's true. They are full of infections. Then late preterm birth, a little IUGR, we give formula, end up in NEC, and there are NECs happening with formula. They are CMPA, blood in the stool, they end up in NICU, put a IV, again an infection. NICUs are the worst place for babies, don't let them be there, if possible. No, not even mine, yes. This is it's an older data, 2016, 10 years have passed from AIMS. So this is Indian standard actually. This is much lower than the Western standard. Luckily in Amrita we could save a few babies less than 24 weeker. In fact there was a twin, 23 weeker twin survived, and that was just luck because the babies, the lungs were good and the obstetrician had taken good care of them. Steroids were given, magnesium sulfate were given, and luckily they were extubated on day one. So sometime luck favors the brave. This is for Dopplers. And if you want to click a photo, and it's a Barcelona protocol, everybody knows it. Sometimes we are just stuck when to deliver. See, even in reverse end diastolic flow, the delivery has to be 30 to 32 week, not early. So only when the ductus venosus changes, even and that is late ductus venosus changes, that is to be delivered less than 28 week. Otherwise, there's no clear indication of delivery less than 28 weeks. So prevention of prematurity is the best treatment for prematurity. You can follow up those. You can do a frequent ultrasound. You can talk to a fetal medicine specialist. I'll wait for a minute. Ma'am, that is easily available, and I can share with you also later on also if you wish. What I tell the see, the practice should be with a little fear. When we are not fearful of the gynecologist, we will be casual sometime. The gynecologist at least have to ask. If you ask your pediatrician, sir क्या हुआ, डॉक्टर साहब क्या हुआ इसका, he'll be very careful with your kid at least. Otherwise ठीक है, चलता है, कोई बात नहीं. One is cord management plan. Say डॉक्टर साहब आप cord का क्या करने वाले हो? Intact cord resuscitation is a new thing coming up. However, in India it's not that easy. But even if you do not give a positive pressure ventilation and you give at least a 30 seconds of delayed cord clamping, that will be helpful. The baby will not get hypoxic because the baby is receiving oxygen and blood through placenta. Only if there is a maternal-fetal bleeding, that is the only indication for early cord clamping. Even RH is not an indication of early cord clamping. So cord clamping plan and CPAP. The neopuff Dr. Bisht was telling, madam, the rate of intubation has really come down in delivery room, even in most preterm babies. Intubation has not remained an emergency anymore. I have intubated less than one baby in a year in our hospital. In last year, only one intubation. That was a fresh stillbirth, but 8 minutes have passed? No, okay. Second is blended oxygen. Sometimes we don't have blenders. We give 100% oxygen. 1 minute of oxygen is enough to cause free radical damage for next 28 days. They cause more ROP, they cause more BPD and lot of issues. Early surfactant, if you need intubation for stabilization. Aggressive feeding, sometimes we are scared. बच्चा छोटा है, फीड मत कर देना, NEC हो जाएगा. मैडम, दैट्स द मोस्ट प्रिवेंटिव थिंग. जितना जल्दी फीड करेंगे, EBM, नॉट फॉर्मूला, EBM, that's going to save the baby. Ask your pediatrician, NEC कम करना है तो EBM दो. और इंडिया में तो इन्फेक्शन इतना ज़्यादा है, जल्दी फीड करोगे उतना अच्छा है. 30 week and above तो enough evidence है, you can start full feed. 30 week and below you can start but aggressive. There have been enough evidences कि अगर aggressive feed, there's no baby even 23 weeks who have survived with me. We did not start feed less than, any baby we did not start feed less than 24 hours. Every baby who is born, if do not require inotrope, will start feed within 12 to 24 hours and will aggressively increase. By 4th, 5th day, most of the babies go into full feed. 30 to 40 ml per kg per day, if to be precise. Sepsis prevention and hypothermia, hypoglycemia. My presentation is finished here only. It's just the extension of it. अगर मेरा टाइम कभी भी खत्म होता है तो please let me know. Cord management plan, the death, need of inotropes, blood transfusion, neonatal jaundice is similar. Otherwise, everything is coming down. And long-term benefits are immunoglobulin and stem cells. It's still controversial, but yes, there are. टाइम हो गया, चलो ठीक है. That was my this thing talk, and everything is extension of it. Just one slide I like to focus on. Even in preterm, there was initially in preterm we should not milk the cord, but now the evidence have changed that at least for 32 and above, अगर आपको early cord clamping करना भी है, even in the clamped cord you can milk. That will increase the hemoglobin of the baby and decrease the requirement of inotropes. And second thing is neopuff. Neopuff is important because it gives you PEEP, and PEEP is more important. Ambus just give you PIP, it just give you inflation, but sustained inflation is required, and PEEP is the most important thing you need. Ask your pediatrician to get trained in it. It just take half an hour to get trained in the use of neopuff. Mandatory, mandatory, mandatory. Third thing is hypoglycemia. Ask your pediatrician, एक D25 अगर कैनुला नहीं डाल पा रहे हो, within 15 to 30 minutes of birth, a sugar should have been checked. If not, adequate, if it is less, give at least D25 in buccal. That's it. At least उसको hypoglycemia एक बार भी हो गया ना, one episode of hypoglycemia is enough to damage the brain permanently. आपको क्यों नहीं सिखाते अपने pediatrician को? सर ने बताया ना, it's very difficult to unlearn. Or ma'am, I'm quite young to tell all of them. Yes, Dr. Vish is going to tell next time. I think I'll finish here. Thank you so much.